Our next speaker is Dr. Arzoo Fatima Saleem. She is a consultant nuclear medicine physician, currently working as head of Department of Nuclear Medicine and PET-CT in Mole. She has a vast experience in her field, including general medicine from SPECT and PET-CT and advanced theranostics. She has played a pivotal role in the formulation of a theranostic team, a board in the country's pioneer theranostic center at Mole. She has multiple projects in her back, and she has mentored many students from PIAS and FCPS nuclear medicine. She has prepared nuclear medicine protocols, lecture notes on management of differentiated thyroid cancer, a practical approach, and PET-CT atlas for oncological indications. Her topic is FAPI versus FDG expectations and reality. Ma'am, please.
Assalamu alaikum. Bismillahirrahmanirrahim. Thank you for such a nice introduction, Dr. Saima. My topic that has been assigned to me, particularly by Dr. Shazia, is FAPI versus FDG, expectation and reality. And I believe for most of you sitting out here, though it's a new kid on the block for the rest of the world as well, but I believe for most of us sitting here in the audience, it is a new entity. So, this is going to be the layout of my talk. I'll be talking about the FAPI concept to just clarify, followed by the diagnostic role of FAPI, including studies and clinical cases, and I'll move on to the therapeutic role of FAPI radionuclides, again, with reference to studies and clinical cases. So let's begin with FDG, because this is what we are comparing it with. As we all know, it's the most widely used radiopharmaceutical for diagnosis, staging, prognosis, and treatment evaluation of many types of cancers. No, not without its limitations, including high physiological uptake in normal tissues, low uptake in some tumor types, and lack of specificity in infections and inflammations. So kindly look at this diagram. This will help you clarify the FAPI concept. What is tumor microenvironment? Well, it's a heterogeneous system composed of extracellular matrix, immune cells, and fibroblasts, all contributing to the complex mechanism of tumorigenesis. So what are CAFs? Well, these are cancer-associated fibroblasts. They are activated fibroblasts highly prevalent in the tumor microenvironment of many cancers. CAFs express FAP, which represents a pan-tumor target. FAP targeting molecules plus radionuclides, that is gallium, lutetium, actinium, bind to this target, resulting in imaging as well as therapy. So what is FAP? Well, FAP stands for fibroblast activation protein, which is a transmembrane glycoprotein overexpressed on the surface of activated fibroblasts, including CAFs in approximately 90% of epithelial-derived tumors. So, is FAP expressed on all fibroblasts? No. It is highly expressed on activated fibroblasts only, and not on resting fibroblasts. So the next question is, do these activated fibroblasts occur only in tumors? No. They are present in benign conditions with tissue damage and chronic inflammation. So what about FAP expression in normal tissues? Well, it is low or absent in normal tissues. Now, does all this make FAPI more tumor-specific than FDG? Unfortunately, no, because FAPI uptake is seen in all sites having activated fibroblasts, like post-surgical wound healing. So what is FAPI? FAPI, or fibroblast activation protein inhibitor, is a novel class of ligands that targets the high expression of FAP on the cell surface of activated fibroblasts. The first clinical use was reported in 1994. Now, why? Because besides all its drawbacks, it is still considered an attractive imaging agent as compared to FDG. Well, due to faster tracer kinetics, high image contrast due to low background in normal organs. Consequently, it is able to visualize tumor stroma formation as small as 2 to 3 millimeters. And FAPI PET is independent of blood sugar levels. So FAPI PET may be more sensitive than FDG PET for detecting small lesions, lesions with negligible glucose metabolism, lesions in brain, oral mucosa, and liver, again due to the low background. And from a feasibility point of view, the ability to acquire scans as early as 10 minutes post-injection, lack of fasting requirements, or the need to withhold insulin/steroids makes FAPI PET imaging easier to perform, particularly in the diabetic and pediatric populations. So preliminary evidence has generated a raging scientific interest in FAP as the next billion-dollar pan-cancer target in the field of nuclear medicine. So gallium-68 labeled FAPI is the one that is most widely used, though F18 labeled FAPI offers an attractive option due to several advantages such as a larger batch size, longer half-life enabling transport to satellite centers, lower positron energy leading to better spatial resolution. Now let's have a look at the oncological journey of gallium-68 FAPI. Well, Loktev et al. Conducted a proof of concept study in 2018 where they first demonstrated high lesional FAPI uptake in 3 patients only with breast, lung, and pancreatic cancers. Subsequently, a landmark study was published in JNM in 2019, reporting gallium FAPI PET-CT results of 80 patients in 28 different tumor types. And this study showed that tracer uptake differed significantly among tumor types, being highest in sarcomas, cholangiocarcinomas, esophageal, lung, and breast cancer. This is the image I believe you people saw yesterday in Dr. Arif's talk as well. And it belongs to this very same landmark study. It was declared as the SNM 2019 Image of the Year. Now what you can see here is a composite of gallium FAPI PET-CT images demonstrating uptake in 12 different tumor entities. So, comparison of gallium FAPI and FDG PET-CT for the diagnosis of primary and METs in abdominopelvic malignancies was published in the Frontiers of Oncology in Feb 2023. It is a very extensive systematic review. It included 13 studies analyzing 473 patients, and the meta-analysis concluded that the detection ability of gallium FAPI was significantly higher than FDG. Another updated review was published in Diagnostics in April 2023. Now let's have a look at the physiological biodistribution of gallium FAPI. As you can see that there is intense uptake in kidneys and bladder only. Variable uptake can be seen in the lacrimal glands, salivary and thyroid glands, pancreas, uterus, mucosa, and muscles. But there is no uptake in brain, in lungs, in liver, and spleen. So let's have this interesting case. A 42-year-old woman with biopsy-proven gastric adenocarcinoma. The FDG PET-CT image A shows no abnormal FDG uptake in the primary lesion in the stomach, depicted by the red arrow, whereas the FAPI PET-CT image B reveals intense tracer-avid mass lesion in the stomach, depicted by the green arrows. FAPI PET-CT also reveals a tracer-avid lesion in liver, leading to upstaging of the disease. Another case, a 51-year-old woman with biopsy-proven right breast cancer. Again, FDG PET-CT image A shows mild tracer avid right breast primary with few faint FDG avid right axillary lymph nodes. Whereas FAPI PET-CT, that is image B, reveals intense tracer avid right breast primary and multiple right axillary lymph nodes, all shown by the green arrows. Another case, a 47-year-old woman, known case of ovarian cancer, status post-surgery and chemotherapy with rising CA125 levels. In this case, the FAPI image is shown as image A, and you can see intense FAPI uptake in liver, suggestive of liver mets, green arrows, whereas the FDG PET-CT is on the left side, showing no significant FDG uptake in the liver. So a head-to-head comparison of FDG and radio-labeled FAPI PET was published in Life in August 2023. It is a very extensive systematic review of literature. It was including all studies that had been conducted up to May 2023. And I will not be going into the details. It included 52 studies. In the interest of time, I think I'll just skip these and move on to the key takeaways from the diagnostic role of FAPI. Well, some benefits of FAPI PET tracers over FDG include a higher lesion to background ratio, fast renal clearance and tracer kinetics, no dependency upon blood glucose levels and resting state. FAPI is more sensitive than FDG for the detection of primary tumors and mets in GI cancers, including esophageal and colorectal, female cancers, including breast and ovarian, head and neck cancers, sarcomas, or urothelial cancers. In peritoneal carcinomatosis, FAPI is more accurate, particularly in the omental cake pattern. Similarly, in intrahepatic and extrahepatic HCC and non-HCC cancers, FAPI has a higher sensitivity and accuracy. But there are certain limitations regarding radio-labeled FAPI, high rate of false positives in the presence of inflammatory processes, though less evident than FDG. False negative scans can result from low expression of FAP in the tumor, small lesion size, and lesions near the physiological uptake sites. Moreover, several studies have not used histopathology as the standard of reference. And finally, because of the small number of patients enrolled, in most of the studies, often retrospectively recruited, additional research is necessary. So coming to the therapeutic role of FAPI. Well, besides the use of radio-labeled FAPI tracers for diagnostic purposes, DOTA chelator in the molecular structure allows the coupling of FAPI molecules with either alpha or beta emitters for therapeutic purposes. Therefore, it has a potential role as a new anti-cancer radioligand therapy. FAPI radiopharmaceuticals have recently been named as the potential novel molecules of the century. A very comprehensive review that summarizes the results of preclinical and clinical FAP-based radionuclide therapies published in JNM in July 2023. Now, all these studies are basically case reports, case series, and small prospective studies. Most have used beta emitters. Recently, a study by Professor Baum used actinium in combination with yttrium-90 and lutetium. Bilal et al. Conducted a study on thyroid cancer only. Overall, the FAPI therapy appears safe with few toxicities, and repeated therapy was also found to be feasible and safe. As far as efficacy is concerned, earlier studies reported disease progression or stable disease. Recent studies have reported a partial response, particularly in sarcoma patients. However, a complete response to FAPI therapy has not been documented yet. Now, this study was very interesting. It was about FAP-targeted radiotheranostics for the treatment of 19 different adenocarcinomas and sarcomas, 4.5 years clinical experience and outcome in 70 patients. It was presented by none other than Professor Richard Baum at the 19th ICRT in Oman in Feb 2024. I do not have the time to go into the details, so very briefly, the eligibility criteria included patients with advanced malignancies after prior confirmation of significant tumor uptake, and 70 patients were recruited, 54 underwent therapy. Response to therapy was determined by molecular, morphological imaging and tumor markers, and it was found to be well tolerated with mild side effects, and there was partial response in patients treated with combos. 2 complete remissions were seen in case of ovarian and colon cancer, and very promising overall survival, that is 9.5 months, was seen in end-stage pancreatic cancer. In total, 19 distant malignancies was treated. As you can see, the highest number of patients treated were those of pancreatic cancer, and with different combinations were used, but the most common was that of lutetium and actinium. So, a case, primary breast cancer with disseminated mets, treated de novo with 1 cycle of lutetium before PTRT, and you can see after 1 cycle of PTRT, partial response. Ovarian cancer, treatment-resistant, extensive lymph node mets, received only 1 cycle of FAP-PTRT, and just look at the images at baseline, at 9 months, at 12 months, and at 18 months. So this patient remained in complete remission for 2 years post first PTRT. Metastatic colon cancer, combo of 3 cycles of FAP-PTRT plus FOLFIRI. And the first set of images show partial remission after first 2 cycles, and the second set show complete remission after the 3rd cycle. Again, a very interesting pilot study that was conducted in July 2023 and published in Thyroid, and it was regarding the FAPI-based targeted theranostics for radioiodine refractory differentiated thyroid cancer. Again, I'll skip the details and just move on to the conclusion, which is that the preliminary data suggests that the novel molecule lutetium dotaga FAPI is safe, seems effective, opens up a new avenue for the treatment of aggressive radioiodine refractory DTC in patients who have exhausted all standard lines of treatment. So the key takeaways are FAPI-based radionuclide therapy has shown encouraging outcomes in multiple malignancies. We are only beginning to understand the potential of this therapy. Extensive research is still underway. Combining FAPI therapy with chemo and immunotherapies remains an unexplored research area still. And to conclude, gallium FAPI outperforms FDG in detecting cancer and offers potential for new targeted radionuclide therapy. At present, the most promising clinical data of FAPI theranostics has been reported in advanced sarcoma, breast, thyroid, and pancreatic cancer. Therefore, it is critical to collect more evidence and design appropriate clinical trials to gain a better understanding of FAPI's exact role and applications in a diagnostic and theranostic setting. So this was to start with topic assigned to me, FAPI versus FDG, expectation and reality. We need to align our expectations with reality. And basically, there are 2 ways to be happy. Number 1, improve your reality. And number 2, lower your expectations. So thank you very much for your patient listening.